Well, welcome everyone. We'll call this meeting to order. If you're able, please join me in standing for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you.
Thank you.
Cheryl, can you call the roll, please?
Yes. Director Yee,
Present.
Director Stewart,
Present.
Director Wallace,
Present.
and Director Epen is unable to join us tonight.
Very good.
Dr. Nicholson,
Present.
Great. Thank you. And who's there with you in the room?
Kimberly Hartz,
Uh-huh.
Chris Henry, Larry Labossiere, Paul Kozachenko, Sri Badu, and myself, Cheryl Renaud.
Okay, very good. Thank you. Well, welcome to the September 14th, 2022 regular meeting of the Washington Township Healthcare District Board of Directors to continue to protect the health and safety of the members of the board, district staff, and members of the public from the dangers posed by the SARS-CoV-2 virus. The Brown Act allows a local agency to continue to hold its meetings remotely, as opposed to being required to meet in person. Section 54953E3 of the Government Code requires that the board make certain findings every 30 days to continue meeting remotely. One such finding is that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote. The Alameda County Health Officer continues to recommend social distancing and the wearing of masks indoors. I refer the public to the Alameda County Health Care Services Public Health Department COVID-19 website at www.covid-19.acgov.org. I ask for a motion that the board make the finding required by section 54953E3B2 of the Government Code that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote.
Madam President, I make the motion that the board make the finding required by section 54953E3B2 of the Government Code that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote.
Thank you. Is there a second?
Second.
Thank you, Dr. Stewart. Roll call, please, Cheryl.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Nicholson,
Aye.
and Director
Can you
Epen.
folks hear me?
Yeah, we can.
Barely.
Hear me?
You're slow.
Okay, well, I'm going to sign off and come back in.
Okay.
Is this better? Can you hear me?
We can. Can you can hear us okay?
Can you?
We can. Can you hear us?
Okay, thank you.
Okay.
Yes, perfect.
Okay, very good. Well, public notice for this meeting, including dial-in information, has been posted appropriately on our website. Tonight's meeting will be conducted by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Moving on to communications, members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Cheryl, were there any written communications?
No, there were no written communications.
Very good, thank you. Then we will move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Hearing none, does any member of the public want to remove an agenda item from the consent calendar? Now then, may I have a motion to approve consent calendar item A, please?
Yes, Madam President, I move that the Board of Directors approve the consent calendar, item A.
Very good. Thank you. Is there a second?
Second.
Thank you, Dr. Stewart. Roll call, please.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Nicholson,
Aye.
Director Eaton.
Very good. All right, so we'll move on to the fun part,
I'm sure you heard
presentation.
me again. Did you hear me?
We can hear you. It's just a little delayed.
Okay, thank you.
Okay. Kimberly, would you like to introduce our presenter, please?
Yes, it's my pleasure to introduce two of our nurses, and they're going to talk about the magnet recognition program, and it's recognition that Washington Hospital has around nursing excellence. And we're very proud of this recognition. And so we have two speakers this evening. The first is Ebitda. She is a registered nurse with a PhD and a Master's of Science degree obtained from the University of San Francisco in 2016. She began her nursing career at Washington Hospital as a new grad on 3 West. She holds an adult gerontology clinical nurse specialist board certification and a nurse executive advanced board certification. Ebitda has grown professionally during her time at Washington Hospital. In 2018, she was the med surg and dialysis clinical nurse specialist and now has expanded her role as the magnet project manager. Next, I would like to introduce Brenda Brennan. Many of you know her. She received her nursing diploma from Little Company of Mary Hospital in Chicago, her BSN from Chicago State University, and her master's degree in nursing from UCSF. Brenda started her career at Washington Hospital in August 1987 as a registered nurse in the emergency department. In February of 1989, she assumed the role of clinical nurse specialist for the emergency department. In 2014, Brenda was promoted to the position of emergency services administrator. In this role, she had responsibility and accountability for the overall strategic and operational planning and provision of patient care for the emergency department and observation unit, and discussion and development around trauma services. In July of 2017, she was promoted to Assistant Chief Nursing Officer with responsibility and accountability for emergency services, nursing education, and magnet redesignation. Brenda has been at Washington Hospital for 35 years and has been very active in many institutional initiatives, including but not limited to disaster preparedness, lean implementation, and COVID-19 pandemic response. But before they start, I do just want to say tonight is probably the last night you'll be seeing Brenda present at this point. She is going to be retiring from the healthcare system as of Friday. And I think we all know this will be a huge loss for all of us, but we're very happy for her in terms of starting that next chapter of her life journey. I think we know she's always advocated for our patients and worked closely with our community organizations. She has a deep commitment to disaster preparedness and played a key role on my team in terms of COVID-19 and really was there during any time that we needed to figure out how to, meet the needs of our patients. She was able to work together collaboratively to do so. I think we all know she has touched many lives and she has really led by the patient first ethic. And I know that Washington and our patients in our community are a better place because of Brenda. So I just want to say thank you, Brenda, for all that you've done.
Thank you, Kimberly.
I miss you, Brenda.
Oh, thank you. I'll miss you guys too.
Wonderful. Yeah. We appreciate all that you have done as a nurse yourself, and then coming alongside and encouraging and educating and equipping our nurses. We know that we are better for it, like Kimberly said. And so we thank you for sharing your gifts, your talents, and your heart with us.
Well, it's been my privilege and my pleasure.
Thank you. All right. So who will begin the presentation? Adelita?
Yeah, Adelita, you're going to share your screen.
Yes. And I hope everyone can see this PowerPoint presentation. I'm very thankful for the opportunity to be here today to speak about our magnet designation. And what is magnet status? It is the highest credential a healthcare organization can achieve. It is the gold standard. To obtain magnet status, organizations must meet the most stringent evidence-based standards of nursing excellence. Organizations that have magnet status foster nurse engagement and the role that nurses play as members of the interprofessional team. Magnet status is exclusive, and as of July 2022, there were 589 magnet organizations around the world. 576 are in the US, 48 are in California, and only 8 are in the Bay Area. The 8 magnet organizations in the Bay Area are Washington Hospital, UCSF, Stanford, Lucille Packard, El Camino, John Muir Concord, John Muir Walnut Creek, and North Bay. The journey to magnet status at Washington Hospital started over 10 years ago. In 2011, we earned our first designation. In 2016, our second designation, and in 2021, our third designation. We are currently working and looking forward to earn our fourth designation in 2025. Magnet status benefits our patients and our hospitals. It enhances acknowledgement of nursing staff contributions and advancement of nursing practice. It improves patient care outcomes, safety, and satisfaction. It reinforces positive collaboration and relationships. It improves recruitment and retention of nurses, physicians, and other healthcare professionals. It promotes nursing staff satisfaction and productivity. It offers competitive marketing advantages, and it offers greater recognition within the nursing community and healthcare organizations. Expectations continue to rise in the magnet community for magnet organizations. And as we move into the next phase of the designation, we have new areas of focus. These are to improve nursing satisfaction, to maintain workplace safety and decrease workplace violence, to encourage our nurses to obtain board certification and commitment to clinical practice, to increase our focus in the delivery of nursing care in our ambulatory areas, to promote nurse-led research studies, and to provide care that reflects a diverse workforce and the delivery of care that shows diversity, equity, inclusion, and cultural competence. There are 5 magnet components that demonstrate nursing excellence in a magnet hospital. They are empirical outcomes, transformational leadership, structural empowerment, exemplary professional practice, and new knowledge innovations and improvements. When surveyors visit a magnet hospital, they verify, clarify, and amplify these 5 magnet components through interviews and direct observation of staff. Transformational leadership is the first magnet component that I would like to review. We are fortunate to have excellent leadership at Washington Hospital. Our CNO, Larry Lavoisier, regularly communicates with nurses in all settings, positions, and shifts in the organization. He participates in executive meetings and supports and advocates for nurses in the organization. The leadership team is robust. We have assistant chief nursing officers, nurse directors, nurse managers, supervisors, clinical nurse specialists, and nurse educators who work tirelessly to advocate for patients and for staff. In addition, nurse leaders and nurses are empowered to participate in interdisciplinary committees and organization-wide committees. These nurses have invaluable experience, knowledge, and insight, and they speak out for their patients and their needs. The next component that I would like to talk about is exemplary professional practice. Our professional practice model supports our mission, our values, and the patient-first ethic. It reflects principles from Mary Mante's relationship-based care and focuses on the needs of the patient and family. At the center of our care, we have you, the patient, and your family, surrounded by your commitment to provide evidence-based practice care, advocate for you and your needs, collaborate with the interprofessional team, and our professional practice. Our model exemplifies the nursing culture at Washington Hospital and the positive impact that we seek to have on patient outcomes, safety and quality of care, patient satisfaction, and staff satisfaction. A third magnet component is structural empowerment. Leaders at Washington Hospital have encouraged and empowered nurses to monitor their own practice through shared governance since 1991. Current councils include Magnet Council, in which we review magnet requirements, the Professional Practice and Education Council, in which nurses and interprofessional team members review the protocols and procedures, as well as changes in the electronic health record, which is used to document care. The Professional Engagement Council, which reviews nurse turnover data, professional achievement, and role development. The Quality and Research Council, which reviews, monitors, and analyzes nurse-sensitive patient outcome data and recommends action as a result of the data analysis. They also discuss research study proposals and provide a forum for nurse researchers to disseminate their findings. The Night Shift Council, which provides feedback to other councils about the unique needs of the night shift as they relate to quality, research, education, and professional practice. There are also unit councils. Nurses across the organization use these forums to communicate patient care ideas, safety improvement opportunities, and patient experience feedback. We are very proud of our highly educated workforce. In 2010, the Institute of Medicine and nurse members of the academies and the Robert Wood Johnson Foundation published the Future of Nursing report. One of the recommendations was for 80% of the nursing workforce to be Bachelors of Science in Nursing prepared by 2020. This was a welcome recommendation, since significant research documents the importance of higher education for nursing entry into practice. In the state of California, every nurse that practices nursing is licensed by the California Board of Registered Nursing, regardless of educational preparation. We at Washington Hospital have surpassed that goal, and as of June of 2022, 87% of nurses at Washington Hospital are BSN prepared or higher. Magnet recommends that nurses obtain a professional board certification that relates to how nurses influence and provide care within the inpatient and ambulatory care settings. Currently, 24% of nurses at Washington Hospital hold a professional board certification. The fourth magnet component is new knowledge and innovation. It is important that nurses generate new knowledge in the science of nursing to advance patient care, patient safety, and patient experience. Current magnet goals call for 2 completed research studies and 1 ongoing research study. Washington Hospital nurses choose to focus on research that helps patient outcomes. In the past 12 months, nurses have produced knowledge on human trafficking, screening and referral, TNK medication administration for patients suffering a stroke, checking of gastric residuals in patients receiving enteral feeding, encouraging patients to increase mobility and its effect in length of stay and patient discharge disposition, and demographic characteristics of outpatient palliative care patients. Nurse satisfaction falls under the magnet component of exemplary professional practice. Nurse satisfaction is critical to magnet designation, and as an organization can only move forward with designation if the majority of its nurses rate satisfaction higher than the national benchmark in 4 out of the 7 categories. Nurse satisfaction scores reflect the perceptions of frontline nurses regarding their professional practice and their engagement. Our next nurse satisfaction survey is scheduled for October of 2022. The American Nurses Association defines nurse-sensitive clinical indicators as measures that reflect the quality of care given to patients by nurses. This data is reported as part of the exemplary professional practice magnet component. At Washington Hospital, we are committed to a culture of patient safety and quality care. We review nurse-sensitive clinical indicator data, plan improvement strategies, implement changes, and evaluate impact of nursing care. In the inpatient setting, magnet requires that we outperform when compared to a national benchmark in 4 nurse-sensitive clinical indicators in the majority of the units and the majority of the time. The majority of the time is defined as 5, 6, 7, or 8 out of the last 8 most recent quarters. The same requirements apply to the ambulatory setting, with the change that magnet has increased the number of nurse-sensitive clinical indicators from 2 to 3 for the ambulatory setting. In the inpatient setting, we are outperforming in falls with injury, hospital-acquired pressure injury stage 2 and above, central line-associated bloodstream infection, and catheter-associated urinary tract infection. In the ambulatory setting, we are outperforming in the fall with injury nurse-sensitive clinical indicator data, and we are in the process of selecting the other 2 indicators that we will use, and plan to start collecting data for this in quarter ending December 2022. We value the opinion of our patients regarding the care they receive during their hospital stay or clinic visit, and strive to provide safe, compassionate, connected care. Our patient-first ethic guides our commitment to every patient and every family to improve patient experience and provide patient-centered care. Magnet has asked us to outperform in 4 of the 9 categories of patient experience in each the inpatient units and the ambulatory care setting. Outperformance is considered when the majority of the units outperform in the majority of the past 8 most recent consecutive quarters. The 9 categories are care coordination, patient education, safety, careful listening, patient engagement, courtesy and respect, responsiveness, pain, and service recovery. We review patient experience regularly and have projects to improve patient experience. We are doing well, and as you can see, our units, clinics, and departments in both the inpatient and ambulatory setting are outperforming in the majority of the quarters in the past 2 years. Our next steps are to celebrate our 3rd magnet designation during the annual Magnet Conference in Philadelphia this October 2022, and to continue to prepare for our next designation in 2025. I thank you so much for your support and your time this evening and for listening to this presentation. And I want to ask if there are any questions that I can respond to you.
Go ahead.
Yeah, Adelaida, what can we do to encourage increased board certification among our nursing staff? And how many different varieties of board certification are there for our nurses?
That's an excellent question, Dr. Nicholson. We have several strategies in place. Our CNO, Larry Lavoisier, and our leadership team is working with one of our committees that we have that I mentioned. We call it for short PEC, the Professional Engagement Council. And they review the different strategies that we can have for nurses to increase their desire to have a board certification. And they also monitor the rates that we have, and they're informed, and they will help in the future to set up the next goals that we have for Magnet. As a Magnet organization, we have to have our baseline data, and we also have to have data for and a goal for year 1 and 2. And right now we are at what we call our baseline year. So we will be having our nurses decide, be aware of the board certification rate we have, and acknowledge the need and the desire to increase that number, set a goal in conjunction with leadership, of course, and they will help us promote those board certifications. Because if they are involved from the start, then they will be more encouraged to follow up with that goal. As in regards to how many board certifications there are, the last time I checked, there were about 300. There are many, many types of board certifications. And the beauty of it is that Magnet actually says it's not just that you have that board certification, but you have to be working on that area. And so it is nice to see, because I have talked to nurses in the telemetry floor, for example, who say, I don't want the med-surg certification, I want a cardiac certification. And so they ask for the specific numbers, or not numbers, but the specific name of a board certification in nursing that is specific to the cardiovascular field. And we do have some of those. So it's nice to have a broad range.
Adelita, may I add to your answer?
Please, yes, Brenda.
So very comprehensive explanation and very nice presentation, Adelita. Dr. Nicholson, one of the other things that we've done this year with Larry's support is we've implemented a culture of learning. So we have a culture of safety in the organization, but we've implemented a culture of learning and been fortunate to purchase many more products that will support the nurses. So we've also contracted with a company called MedEd, and we'll be offering the nurses free certification classes for them to prepare for these board certifications. And then there's also reimbursement to incentivize them to take the certification exam so that it's not a financial impact to them.
That's all beautiful. That's really good news. That's just music to my ears. Thank you very much, Adelita and Brenda.
Thank you.
Very exciting. Thank you. Now, is it a minimum for hiring that you have to have your BS for nurses?
So it has been our standard, Jeannie. We have had some challenges recently in terms of finding applicants, right? Because there's such a shortage of nursing.
Okay.
And so we have a little small test of change going to accept associate degree nurses with a minimum of 3 years experience in their specialty.
Okay.
Just as long as we don't dilute too far that 87% rate of BSN. So as long as we stay above 80%, we think that there's an opportunity to encourage some of our ADN nurses in the community with clinical experience to apply.
Thank you. I know that there's challenges with that recruitment and all.
True.
Well, I appreciate that. Thank you, Adelita. Any other comments or questions from the board members? We appreciate all that you do. Once we got that third designation, it's like you don't get a chance to take your breath, catch a breath. You're working, continually preparing and challenging yourselves and the nurses. And we can't thank you enough for all the work that you do for making sure that benchmarks are met and exceeded, and our patients are getting the very best care. So we thank you.
I would like to add to that. Magnet does focus on nursing, but it certainly takes a village.
Oh,
And there's no way to achieve this kind of designation that's not an organization achievement, because it takes everybody to achieve it. And if you were around when the Magnet appraisers came, it took more of a village, because IT had a huge piece in the remote appraisal of our Magnet accreditation. And we're so dependent on everybody from EVS to respiratory to all the ancillary departments. And Magnet actually has a focus on interdisciplinary care as well. And so we would be remiss if we didn't reflect on it being an organization-wide designation, not just for nursing.
very good. Thank you. Thank you, Ebitda, and thank you again, Brenda. We wish you the best on your retirement. Many happy, healthy, and enjoyable years catching up on what you've been missing.
Thank you for that.
Thank you for your sacrifice. Thank you.
Thank you.
Good evening. All right, let's move on. Medical staff report with Dr. Hyder. Good evening. You can take yourself off mute. There you go.
Hi, good evening to all. Thank you so much. That was a great presentation and
Yeah.
quite informative also. So on my first thing is so our medical staff number is, we have an active 337 physicians, administrative 1, allied health is 36, ambulatory is 95, consulting is 8, courtesy is 25, provisional 67, and leave of absence 6, and total is 575. And yesterday we have a general staff meeting, and it was very well attended, and there was a good presentation. And there was a presentation on clinical documentation improvement, and it was how to initiate that. And it was given by Dr. Jack Rose and Dave Knapp, consultant clinical intelligence. And also there was a clinical intelligence requested changes to system smart phrases to improve documentation that's criteria in clinical condition. That was given by Laura Baker, app analyst and RN information from information services. And Larry Labrousse, he talked about level 2 trauma center designation given to us, and we are moving ahead successfully, and we have contacted Bishop Group. And also, as we all know, that the vaccination is for the staff is allotted for flu as well as TB testing on September 22nd, starting at 8 o'clock. And the next day they are going to give COVID vaccinations too. So there was a little issue because it's 2 are back to back, and sometimes, if somebody receive it, they will have some fever, malaise, body ache, headache, and then goes again second day for COVID, but probably they can again take it, giving some gap. Dr. Diane Martin was asked about this, and she recommended also that at least 2 weeks interval should be there in between, because not head to head, just next day. And the other thing was the Top Hat is on October 8th, Saturday. That is the 36th annual Top Hat Gala under the Grand Tent at Washington West. And the funds which will be raised through Top Hat will be used to acquire life-saving equipment and technology for Washington Hospital new level 2 adult trauma center. And everybody is requested to attend that and make it successful. This is the end of my report.
Thank you very much, Dr. Henry. Thank you.
Thank you.
Moving on, Debbie Fury with the Service League report.
Hi, good evening, District Board, and greetings from the volunteers. In the month of August, the Service League volunteers contributed 2,272 hours to the hospital. During the month, 181 volunteers staffed their assignments. We saw a big increase in the number of volunteers during the month because of our college volunteers. They staffed a few extra hours before returning to school. The interest in the orientations have been really strong, and we hosted an orientation in August that attracted 2 adults, 10 college, and 29 high schoolers. So our high schoolers are back. With the staffing assignments in the main lobby, which is now open, they are also volunteering in the birthing center, which is now back open for the high schoolers, and they're handing out snacks and beverages. Our Pinky Puppet ladies, Kaz, her name is Kaz, being the most creative, has created this little quilt. It's really cute. And it's all done by scraps. She takes all these scraps and she makes these different little quilts, and they're handing them out at the birthing center. And they can be used as burping rags or to put on changing tables. I just think they're so adorable, and they're all different. And that's my report. Do you have any questions?
Thank you, Debbie.
No problem.
The volunteer she's talking about, Kaz Imish, was a hospital employee in pharmacy, I believe. Anyway, she retired and she became one of our quilters, and she is a whiz at taking scraps and turning it into artwork. And our patients get the benefit of that. So it's nice to see our employees that stick around and continue to give to our community. Thank you, Debbie. All right, our quality report is next. Kimberly, would you do the intro, please?
I will. It is my pleasure to introduce Dr. Diane Martin. She's been a member of Washington Hospital's medical staff since 1984. Dr. Martin has served in many leadership roles at Washington, including chair of the Department of Medicine and chair of the Clinical Evaluation Committee, which includes pharmacy and therapeutics and infection control. She has been a physician champion for many of our campaigns, including the 5 Million Lives campaign, and she's also analyzed data and educated her peers on infection control issues, especially MRSA and also COVID. Dr. Martin attended the medical school in Charleston, South Carolina, after which she completed her internship and residency at the University of Kentucky School of Medicine. She received a fellowship in infectious diseases at the UC Davis School of Medicine. She serves on the board of Life Elder Care and is a member of Washington Township Medical Foundation. I also just want to say that I think many of us know she's a very valuable resource to both physicians and staff in many areas, and especially infection control, and has played a key role in many programs that have helped to improve the care that we provide to our patients. So thank you, Dr. Martin.
Thank you. So, Sri, you're going to drive my slides. Thank you. Okay, so we're going to do a whiz update of flu and COVID and MPX, which is also known as monkeypox. Next slide. So talking about the 22-23 influenza season, generally we think it's going to be very similar to what we've seen before, that there may be less influenza because of the continued measures that we're using, such as the masking that you're seeing our board staff using. Also, we do see the influenza and SARS-CoV-2 co-circulate. So sometimes it's very hard to tell at this time of year if somebody has a COVID infection or an influenza. people can be infected with both of them, unfortunately, at the same time. Next slide. So influenza and COVID-19 are both very contagious. They're respiratory illnesses, but they are caused by different viruses. They are of the same genetic. They are both coronaviruses. COVID-19 is a relatively new infection that we've seen by the coronavirus. The ones we see now are the SARS-CoV-2. Flu is caused by influenza virus, which is also a coronavirus. So both COVID-19 and influenza have very similar symptoms and can vary depending on how contagious the virus is to the particular person, what their immune status is, and whether or not they've been vaccinated. So common symptoms that we see in both COVID-19 and flu are fever, feeling chills, shaking, cough, that can be mild or very productive, feeling short of breath, or having difficulty breathing, taking a deep breath. We also see fatigue, sore throat, runny nose, stuffy nose, muscle aches, body aches, headaches, and actually some vomiting and diarrhea, although this is more common in children than adults. We do see this sometimes as a presenting symptoms for both COVID and influenza. So you can see there's a lot of overlap. And what we've been looking at in the clinics, as well as the urgent care and the emergency room, is a very similar presentation, and it takes a lot of sleuthing and testing to sort of sort these out. Next slide. So both flu and COVID-19 are spread by droplet. So when a person coughs or sneezes, that's how it's spread, or very, very close contact. You've probably seen those photographs where it has the cough backlit. You can just see the spray of the droplets that include the virus coming across. And sometimes that can go out for several feet. Occasionally, people can be infected by touching objects or surfaces, but this is much less frequent because the virus only exists with live contact, not inanimate subjects. So generally, if you're sneezing, coughing, touching someone, or touching something that has the virus on it and then touching yourself, then you can spread the virus that way. But that is less common than direct exposure to someone else who has the virus. So both flu and COVID-19 can be spread by other people before they begin to show symptoms. You know, a lot of you have heard of people who are asymptomatic and they don't develop much symptoms at all, and people around them get very seriously ill. So they may have very mild symptoms or no symptoms at all. We call that asymptomatic. There are very significant complications to both flu and COVID-19. We can have bacterial infections such as different kinds of pneumonia, sepsis, respiratory failure, where someone actually might have difficulty breathing, needing supplemental oxygen, or sometimes even being intubated. We see that less now than we have had in the past, but it continues to be a concern. A lot of times people have neuromuscular complications where the muscles get weak, they don't breathe as effectively, they don't move as effectively, and generally have more generalized weakness. We also see lung complications. The diffuse congestion of the lungs can be upper lungs, lower lungs, entire lungs just crowded with the viruses. We see cardiac complications. Sometimes this gets into the muscle of the heart and causes weakness and congestive heart failure. Many times we see patients needing hospitalization, and we also see people who die from either one of these illnesses. It was quite a bit more common a couple years ago for the high mortality. We have had less mortality in the last year, but we still are seeing very severe illnesses. There's also what they call the long COVID, which even though somebody may have mild symptoms, they continue to have a fatigue or difficulty concentration, cognitive issues that can go on for months to even years, as far as we know, because this virus has been around for 3 years now that we've seen. So there's a whole range of complications from both of these viruses. Next slide. So what is a flu shot? Flu shots are vaccines that help the body develop antibodies. In other words, to help the body protect against an incoming infection. And research has shown that the most common viruses are changing each year. So this year we're seeing the influenza A strains, H1N1 and H3N2, and 2 of the B strains, the Victoria and the Yamagata. So these are the ones that we think are most likely to be circulating. We're trying to predict this in advance each year. Some years we're very accurate with it, and sometimes a little less accurate with it. But nonetheless, the body builds on the vaccine from year to year. So it does help, even if we don't have it exactly right. Many of these viruses are similar enough in the vaccine that you had the year before, similar enough to provide protection. So even though somebody may say, well, there's less influenza last year, doesn't mean that we're necessarily going to see that again this year. So it would be very important to continue to get flu shots. And in Washington Hospital, we make this a very strong recommendation for our staff. Next slide. So the flu vaccine is recommended for anyone 6 months and older. And like I said, our high-risk persons include our essential workers, which are our healthcare personnel, and those that work in nursing homes, long-term facilities, pharmacy staff, our critical infrastructure workforce. I mean, we couldn't do without our dietary, our EVS, any of the other support staffs. We could not run this hospital without them. So they are considered essential and extremely valuable. We also see persons at increased risk for severe illnesses from COVID-19. So as we age, our immune system gets a little weaker over time. So these are the people we want to target specifically to make sure that they get vaccine for both influenza and COVID-19. So 65 years and above, people who are in congregate living, whether it's a skilled nursing facility or a board and care home, individuals who are immunocompromised, say someone who's recovering from cancer chemotherapy, someone who's on dialysis, people who have myasthenia and other weakened muscle structure that makes them more susceptible. There are also certain racial and ethnic minority groups that are disproportionately affected. We see that more in our homeless population as well. And we see it in certain ethnic minorities where they're just much more susceptible because of their immune system. People who are high risk for influenza complications include the very young children, children with neurologic complications, women who are pregnant are very susceptible. And again, adults 65 and older, and people who have other underlying medical conditions, so like emphysema, diabetes, patients who are on dialysis are much more susceptible to viral infections. There are groups of people who should not get the vaccine, and those are ones who have had life-threatening allergies to the flu vaccine. And the most common one we see is what's called Guillain-Barré syndrome, where they get a very diffuse muscle weakness, and this can be life-threatening. So those persons should be excluded from getting the vaccine. Next slide. So people say, I have a bunch of questions I want to ask about flu. So how does it actually work? So the flu shot basically, it encourages your immune system to make antibodies against certain strains of the influenza, and it builds on them year to year. Like everything else, it's not 100%. It's very good. So you have about a 40 to 60% lower chance of getting seriously ill than someone who's not vaccinated. We do think you should be getting the flu vaccine every year because the virus does change and the vaccine also changes. And we do show that your immune system builds on this year to year. And the more consistent someone is about getting the influenza vaccine, the more resistant they are to getting infected, or at least not as severely infected. Recommendation for getting the flu vaccine, we sometimes start as early as September, but we target at least by October. People can get it later in the year if it happens to not be available. It takes about 2 weeks once you've had the vaccine to get an immune response. So obviously sooner, better. We think that once you get it, that immunity lasts for about 5 to 6 months. We know in the past, sometimes we've seen surges in March and April. So getting your vaccine, even in September, October, would protect against those. We've not seen that recently, but it has occurred in the past. So the next slide. People always say, well, I think the flu shot was going to give me the flu, and it's usually not the case. You can get a mild reaction because your body is seeing what you've had before, and some people do get a little bit of fever, achiness in the muscles, maybe a little bit of cough or congestion, but usually very minor. So the vaccine does not give you the flu. The antibody reaction may be what somebody is getting reactions to. Flu shots are made in two different ways. One is an inactivated virus. So we take it and basically change the virus to make sure it's not infectious. So that's why the flu vaccine does not give you the flu, but it does provide the antibodies that your system needs to fight off the flu if you were to get infected. The other way we see is recombinant, where basically a bacteria has taken part of the flu virus and made antibodies that we then make into a vaccine. Those kind of vaccines are very similar. The shingles vaccine is made that way. The hepatitis B vaccine is made that way. And also papillomavirus vaccine is made that way. So why do some people feel not well or feel ill after getting the flu shot? Some people think that it's the same as the flu, but it's just your immune system reacting to it and providing you with an immune response. There may be some soreness at the injection site, and that's again a sign that your body is building up immunity to this vaccine to provide you with protection were you to get the flu. Very rarely do we see somebody who gets fever or weakness that can last up to a few days. That's extremely rare. But the symptoms itself are much less severe than if you were to actually get the flu. Next slide. So what is Washington Hospital doing? We are screening and vaccinating all eligible inpatients. So if someone's coming in, whether being admitted for hip surgery or being admitted for a cardiac procedure, we are screening and offering vaccine to all of those patients. We have flu vaccines that are available, both the regular and the high dose. For our healthcare workers, we are requiring mandatory vaccination, proof of vaccination, in addition to mandatory masking for all healthcare workers, which is per Alameda County. We also provide preventative measures for all of our healthcare workers, such as universal masking, eye protection, to try to prevent any of their contact with people that have flu so that they are protected themselves. Hand hygiene is number one. We want to make sure people are washing their hands before, after you're touching somebody or providing care. Hand hygiene is mandatory. We actually have screening surveys for this. Right now, we're ranging about 90 to 90% of our staff are compliant with hand hygiene. Obviously, we like 100%, and we realize sometimes you're in a hurry, you want to provide care, there's an emergency, you're not reaching out to get your hands sanitized, but for the most part, we are very compliant with this. Regular evaluation and analysis of our results, we do that on an ongoing basis. We look at annual analysis of our employee vaccine rates. We look at quarterly evaluation of the patients being vaccinated. So we're doing a wide range of things to try to make sure that we are keeping track with our vaccine rates among both our patients as well as our providers. My screen went blank, sorry. Okay. So we're also monitoring within the emergency room influenza-like illnesses. So they are screened. Patients coming in that look like they have influenza are being screened. Our screening tool right now is a nose swab, which picks up the SARS-CoV-19 virus, screens for that. The influenza virus, that's the common one circulating now. We also do respiratory syncytial virus, which we see more in adults than in children. So that is what we do primarily for our patients coming in. They were suspecting have influenza or viral-like infections. Next slide. So this is talking a little bit about COVID variants because that's a sort of a hot topic now. So viruses do mutate and create new strains of their own virus, and that's called a variant. So the COVID variants in the United States, we are monitoring them by sequence-based surveillance. So that's where we're looking at the genetics of the virus to try to see what their infectious rate is, what their transmissibility is. And we do that by laboratory studies and also epidemiologic investigations. These are somewhat difficult to do. Alameda County is also working on this, as well as California Public Health Department. The variant classifications are a variant of interest, a variant of concern, a variant of high consequence. So a variant of interest is ones that have genetic markers that we can identify that make them specific viruses, and they have specific transmissibility, severity of illness. A variant of concern for the COVID right now is the early one, which is the Delta, where there is difference in transmissibility, how well the virus goes from one person to the next, how severely the person is affected. In other words, if they're very severe, person might be hospitalized or at higher risk for death. The variant of high consequence is something along the lines of the Omicron variant. So this is one that again is of concern because it's more highly transmissible. It does not have as serious an effect on the person in terms of extent of illness as the Delta, but it's still highly contagious and does affect many more people. So we want to look to that. So we're trying to monitor and vary the COVID vaccines to be able to cover these variants. Next slide. This is data from Alameda County, which is showing that we're doing very well in terms of our rates of vaccination. So as of 8/25, we had almost 80 million doses administered, and about 72% had primary series, which is considered 2 vaccines, and then 58% had 2 plus at least 1 booster. So at least 92% got 1 dose, 85% got at least 2 doses. You can see on the right-hand side by areas of locations. You can see Fremont, we've highlighted, we're about 95% have had at least 1 dose, and fully vaccinated, which is considered 2 doses, at 82%. You can see across the bottom section, gender varies a little bit, age varies a little bit, and ethnicity also varies a little bit. Next slide. So the COVID vaccine update, and I sort of preface it by saying, tomorrow this might be different, but this is what it is today. So as of August 31st, the Federal Drug and Food Administration authorized the use of Moderna and Pfizer bivalent vaccines for an additional booster dose. And they were saying 2 months. Now we're stretching it out a little bit to 6 months. So you can do it as close as 2, but 6 probably works better with the immune system. So this is for persons who have had the primary series and 2 boosters. This is another booster. The Moderna is for 18 years and older. The Pfizer is for 12 years and older. The next couple of slides are a little bit busy, and they're mostly just for reference, but just to kind of show you what the sequencing is in terms of timing of the vaccine for those that are vaccinated, not vaccinated, year, and immunocompromised. So we'll go through the next couple of slides slowly, but I know they're kind of busy looking. So this is vaccine timing. So the 6 months to 4, which is called infant. So the Pfizer is 1 dose, and at 8 weeks a second, and then 8 weeks later a 3rd dose. There's a lot of concern among some of the virus experts that probably needs to be lengthened, but this is the current CDC recommendation for now. For those that are on the Moderna, it's a 2-dose series. For the pediatric, which is age 5 to 11, the Pfizer is 1st dose at 3 to 8 weeks, 2nd at 5 months, and then a monovalent booster at 5 to 11 years. 6 to 11 years is Moderna, 2 doses. At age 12, Moderna, again, 2 doses, and then the bivalent. 12 plus years, the Novavax, which was just recently released, 2 doses followed within 2 months, which may be extended to the bivalent booster. 12 years is the Pfizer, 2 doses followed by the bivalent, and Janssen, the J&J, is 18 months and followed by the bivalent booster, which can be either the Moderna or the Pfizer. J&J is not preferred, but I know a lot of people feel a little more comfortable with that. So I'd say whatever gets people vaccinated, we support. Next slide. This is again going to, a little bit of the vaccine timing update. And this is for people that are moderately or severely compromised. So you can see extra doses putting in that series for those that are immunocompromised persons. So either diabetic or chemotherapy or dialysis or immune system problems such as myasthenia, rheumatoid arthritis, etc. Next slide. So for our healthcare personnel immunizations, our COVID primary series, we're at 97%. Our COVID primary plus booster at 94%. This is for Washington. Our unvaccinated, for whatever reason that they can't take the vaccine, those persons are tested twice a week to make sure that they are COVID test negative. We do annual blitz every year for influenza, and we've already started that for September for many of our physicians, our employees, so that we make sure that they get protected. We continue to educate and support the staff if they have questions or concerns. We make ourselves available. We have flyers. We have people on standby if they have questions. So we want to emphasize how much importance we put into this, that we want to protect our healthcare providers and make sure that they have top-notch medical care. They can then turn around and provide top-notch medical care to our patients. Next slide. So prevention and control measures that we're doing. So Washington Hospital works to reduce transmission of COVID-19. We screen for symptoms on patients coming into the hospital prior to, and also on arrival. So prior to would be someone who's coming in for, say, an elective surgery. On arrival will be somebody coming into our emergency room. If the patient is symptomatic, we isolate immediately. Respiratory, PPE, everything. We have universal masking for everyone that comes into our facility. Patients, families, visitors, everybody. We think and respect this as highly serious, very serious, that we make every accommodation to make sure that we provide a safe environment for our workers as well as our visitors and our patients. We have a safe restricted visitor policy. We either require proof of vaccination or negative COVID test. There are some groups that are excluded based on life events, and that would be, for example, parents at birth, pediatric visits, and also end-of-life visits. All of our surgeries require mandatory COVID testing and that they be negative. We occasionally will have a patient where it's an emergency surgery. They test COVID positive. We take extreme measures to make sure all of our staff are protected and the person is treated with respect, but maintained isolation. All admitted patients are also tested for COVID. They have designated areas if they test COVID positive, where we provide isolation and PPE for all of our workers, but we make sure that all patients who are admitted are tested. We also communicate and plan each of these working with the county and public health department. Next slide. So our prevention and control measures, we adhere to respiratory hygiene. So that's our mask, coughing etiquette, where we encourage people to cough into their arm rather than to the hand, and also hand hygiene. We try to strive to maintain 100% hand hygiene. That would be my goal and my dream. I think we'll get there, and I'm hoping it's soon. We do physical distancing, so at least 6 feet between patients throughout the hospital, like the waiting areas. You may see that a lot of times patients coming in for visitors or patients coming into the main lobby, they are distancing 6 feet apart. We're doing that in all of our waiting areas, in the lab, where the patients are waiting to get tested for testing COVID if they're going to be admitted for surgery coming up. We also increase the frequency of cleaning surfaces so they can decontaminate and do environmental cleaning throughout our entire hospital facility. We maintain a constant supply of personal protective equipment. So that's masks, PAPRs, which are basically hooded things that provide extra circulation for people that can't use the masks. We have gowns, we have gloves, and if necessary, we provide things for our visitors are coming in if they're seeing a patient who's in isolation. We are totally following national standards for healthcare worker safety. Next slide. So you may say, after all I've been asking of what we do for our staff, what can you do? Get your COVID-19 vaccine and boosters. Get your flu vaccine every year. Practice good hand hygiene and personal hygiene. Make sure you're washing your hands, whether you're going into the grocery store or you're working in your garden or you're, meeting and greeting family and friends. Cover your mouth while you're sneezing. Wash your hands regularly. If you're ill, stay home. Social distancing when you're in the grocery store or you're in the mall or you're in a restaurant or facility. Wear a mask if you're not eating. And if you're sick, please come visit us. We will be delighted to take care of you. So don't delay care. Don't worry. We're going to take excellent care of all of our patients. And we will make sure that you are provided a safe environment and respectful environment. Next slide. These are a couple of the monkeypox because we kind of thought maybe it would be kind of interesting just to update people on monkeypox. This is another one that's constantly changing. Monkeypox, which is now called MPX, is a very rare disease that's infected with a monkeypox virus. It is the same family of virus as smallpox. So the MPX symptoms include a rash that can look like pimples or blisters. A lot of times that looks like shingles or herpes virus. Other times it looks just like COVID and flu, fevers, chills, body aches, headaches, fatigue, and respiratory symptoms, sore throat, cough, congestion. Onset can be within 3 weeks of being exposed, but generally symptoms start within a few days of being exposed. And exposure is someone who generally has a rash, but again, they can be asymptomatic spread as well. The MPX spreads through close personal contact, so skin to skin and someone who's been infected with the MPX. Sometimes it's by touching objects that that person who had MPX had used, such as clothing, bedding, towels. All of those things can transmit MPX. That's not true of COVID. That's not true of flu virus. We think that possibly MPX can be transmitted by respiratory secretions if a person who is infected with MPX is coughing or sneezing. But usually that's a very close, prolonged contact where you're in with someone in a very intimate situation where you're very close contact. That's pretty rare, and we've not seen much of that in Alameda County. Usually you want to stay isolated when you have these sores so you're not potentially infecting someone else. And the sores need to be completely healed. So basically, most of these sores look like little blisters that have sort of a pus-looking type fluid in it. They then crust up and they can either get flat or rounded. And then after those scabs, and we tell people not to help them off, but after that scabs come off by themselves and they have a fresh layer of skin so that it's clean, then that person is no longer infectious. So they need to go through the whole process of weeping blisters, scabbing blisters, clear skin to then be non-contagious to somebody else. Next slide. So MPX, we actually have over 200 now in Alameda County. So you can see this is changing quite a lot. We are reporting those among Alameda County residents, and there's over 2,500 in California. Most of these to date tend to be in people who have close personal contacts, such as gay persons, people who have had very intimate contact with people who've been ill, in very close environments where they, hang on, I lost my slides again. Hang on. Values of technology. I have my own copy, so you just can't see me. So we basically think this is people who have gay, bisexual men, other people who have sex with men, but other can be heterogeneous. If they're very close contact with each other, they can spread the virus. To date, we have not had any deaths with the MPX virus. We have hospitalization, but extremely low. For the most part, the cases are very mild and don't seem to have prolonged infections. There is a vaccine, the Janios vaccine, which we have available from Alameda County that we're actually distributing at Washington Hospital through the tent. And this is for people who have either been exposed or at very high risk, such as sex workers, or someone who's been exposed to some of the confirmed case. We also want to protect our laboratory workers. So people who are working either in the lab monitoring and dealing with the virus, doing swabs or cultures, or our healthcare workers, such as an ED or on the medical floor, that are dealing in very close contact with patients who are infected. So clinicians who are at high risk basically want to make sure that they are protected as well. So the next slide shows you how you can get vaccinated. So at Washington Hospital, we have the COVID vaccine clinic. Appointments are required. And this can then also be done for the MPX virus, influenza virus, and COVID virus. Those generally are on different dates. So if you don't get exactly the date that you want, that's why, because we're trying to just focus on particular cohorts so we make sure everybody gets adequate providing. You can use the online link at whhs.com. If you're using the MyChart, you can also go through there. And then there's also a vaccine hotline, which is 510-248-8200. We can also get the flu vaccine at most of the Washington Township Medical Foundation clinics. There are multiple locations throughout Fremont, Union City. The flu shot hours for the most part are Monday through Friday, 11 to 4, Saturdays and Sundays, 12 to 4. But you probably want to check with the location and verify those hours. We do encourage appointments, but appointments are not totally required. So you can get vaccines provided through Washington Hospital. They worked very closely with Alameda County to provide both the COVID vaccine and the MPX vaccine. So I will take questions.
Yeah, Diane, this is Bill. Just a couple of questions, one on flu, one on COVID. The flu question is, can you comment on the high dose flu vaccine? Who should get it and what additional benefit does it offer?
We encourage the high dose vaccine for people 65 and above, or people who are moderately immunocompromised. So if you're someone who's diabetic or on chemo or renal dialysis, we consider all of those immunocompromised. Also, people that are living in community settings probably need to be considered for high dose vaccine.
How much additional benefit does it offer over the standard dose in those populations?
I don't know that they've statistically looked at that, but I'd say it's probably at least 20 to 30% over what you would get from a regular. So if you have access to only the regular as opposed to the high dose, you know, by all means, go ahead and get the regular dose because it does provide immunity. We just think that people that are a little bit older, immunocompromised, might not respond as well to a regular vaccine, and that's why the high dose is preferred.
So it's worthwhile to seek it out, but otherwise get the standard dose.
Yes, and I think some of the pharmacies also have the high dose as well. Yay.
Good. So the second question is on COVID. We've seen a lot of COVID cases in the last 2 months, especially in our fully vaccinated and boosted population. The disappointing thing I've seen is when I'm out and about in the community, the wearing of masks has really, really dropped. And do you think there's any correlation between these two things? And why do you think the masking has dropped off so much? Are people just getting complacent? Are they seeing that people who get COVID are having mild infections, so why bother?
So really good questions, kind of complicated. So California has kind of dropped the masking recommendation. We look at the masking. I think it's very important for our hospital community, because we're dealing with almost 100% immunocompromised people. And I think any transmissibility that we might have to them or them to us is very important. So I think within our facility settings, such as our clinics, our hospital, I think we should continue masking. I know for social areas, California has said it's probably not as necessary. It's a little more seeing more of it, I think, because of the Omicron. The Omicron is much more highly transmissible, much more contagious, much more likely to cause infection, but also has a symptomatic presentation. So we do see that. The Omicron tends not to be as serious as the Delta. And again, it's a little hard to tell because we have still a large majority of our residents in Alameda County have been vaccinated at least one dose, which we do think is very protective. So it's a multifaceted. The Omicron is much more transmissible, doesn't provide as much severity of illness, but we are still seeing surges within our hospital community of COVID vaccine and uptake, or what I worry about is what we call vaccine fatigue. People say, I already had 4 doses, why I need another one? So I think that's very important. And I think going forward, we need to sort of encourage people to go ahead and get your vaccine, just like we do flu vaccines every year. I think we're looking at COVID vaccines every 6 months at this point. We do see surges in the hospital census of COVID. I mean, it goes up and down quite a lot. So I'd say the end of this is not anywhere close. And the more that we can do hand hygiene, social distancing, getting your vaccine, keeping yourself healthy, visit your doctor when you have other concerns is very important.
Thank you, Diane.
Diane, I had a question on the 2 vaccines, the COVID and the flu. We heard from Dr. Hyder tonight. You're recommending 2 weeks in between the 2.
I just think it gives your immune system a chance to respond to the vaccine. So if you have somebody who, say, has some limitations and they can only come in one time and you have available to get both the vaccines, yes, go ahead. If you are somebody who's discretionary, you have access to transportation, you have access to come in and get them at 2 different times, I think it makes more sense to give your body time to react to that vaccine, make the antibodies, and then get the next one. But, obviously, if it's a very limited place or someplace that, like a nursing home where they may only be giving it because they only have access on that day, the flu shot is an individual one. The COVID vaccines are 5 or 10 in a vial. So you can see if you're going to open up the vial, you don't want to just do one person. You want to do as many as you can. So if you're in a nursing home situation where you've got, 80, 90 people, it certainly makes sense to do everybody all at one time because you may not have the resources to come back and do it again.
And there's no advantage getting one first or the other one second.
As far as I know, not. I would say that's a really good question, but I don't think anybody's looked at that.
Thank you. You had mentioned the vaccine fatigue, and just the people that I've spoken with about this new booster, I'm hearing a lot of, well, I still got it. I got boosted. I still got COVID. What's the point in getting another booster? Who knows what good it's going to do? Who knows what bad it might do? I think I'm going to skip it.
So that's pretty good, but hopefully what we're looking at is that somebody does get infected, they don't get as seriously infected. And there's still this out there of the long COVID, and we don't know how that works and what it really means. So I would say that part scares me more than being sick for a couple of days with a runny nose and a cough and congestion. What it does to my thinking pattern, my reasoning pattern, when I get to be OLDER and my brain doesn't work as well, I want every resource I can get. So I would try to avoid getting COVID if for no other reason I don't want that complication.
Nice.
So it's a very selfish complication because I'm already OLD, but I want every piece of ammunition I can get.
Appreciate that. Thank you.
I'm sorry to be double checking, but we also heard tonight that probably better to wait up to 6 months before you get the COVID?
There's a lot of controversy among quote unquote experts. So I think CDC is looking at trying to make sure as many people as possible get the Omicron variant vaccine, the bivalent. But a lot of people argue that waiting up to 6 months, and if you've been infected, getting that Omicron variant within 3 months after an infection is like a double bump to your immune system. So you get a natural immunity, but then you get the bump from the Omicron back to back. So I think it's not totally resolved, but I think a lot of the experts are out there saying it's better to wait. A lot of it may depend on the individual's circumstances. I mean, if you're lucky enough to be traveling and you're going to be going abroad and you're going to be in airports that are crowded and other areas, I would certainly get it sooner rather than later. If you're at home, pretty much working from home, and you're not socializing too much, you might want to consider waiting. So I think you have the option of doing it at 2 months, 3 months, 4 months, 6 months. I think you can sort of tailor it to however you think.
Thank you very much.
As she looks into her crystal ball, she gives us these wise answers.
Well, I mean, it's like, this is like the infectious disease doctor's dream of things changing faster than we can keep up straight with it. So we're educating as many people as we can as fast as we can.
We appreciate that. Thank you.
Okay.
Great. Anything else for Dr. Martin before we let her go?
So I can always take questions later. So if there's things that come up, people can either email or call me in at the office number, and I can try to take time out between patients and answer questions, because I know it's important. If somebody needs reinsurance or information to sort of convince them that vaccination is as important as the rest of us think it is, I'm all for it. So I thank you for letting me bring this hot topic up to date. It's certainly near and dear to my heart and stuff that I've trained with for so many years. I appreciate all the support that Kimberly and her team brings. And I can't tell you, Brenda, how much I think of you. She has been a calm force in the ED. You would never believe how much whirlwind goes on there. And she's this calm in the center.
Oh, we're going to miss her.
Yes. All right. Okay.
Thank you. Have a good evening.
Thank you. Okay. Bye.
Bye. That was very helpful. Okay, on to a different kind of health in the hospital, our finance report with Chris Henry.
Okay, thanks, Director Yee. Tonight we'll be looking at the operational and financial results for July 2022. And we'll start with our acute inpatient statistics. Our inpatient average daily census for July was 160.1, a bit higher than our budget of 140.6. When we add in our outpatient observation days, which are patients in a bed but not considered inpatients, we have a combined average daily census that was 169.4 in July. We had expected 150 in the budget. Admissions for the month were 62 higher than budget at 853. Our patient days for July were 4,963 against a budget of 4,358. Outpatient observation equivalent days for the month were pretty close to budget, 3 below budget at 287. And our average length of stay based on discharges came in at 5.49, very close to the budget of 5.51. Moving into utilization, our case mix index for the month came in at 1.599, just slightly higher than the budget of 1.582. We had 138 deliveries in July, 14 higher than the budget of 124. Our surgical cases for the month were 24 below budget at 341. And likewise, our Cath Lab cases for the month were 40 below budget at 180. Outpatient visits in July came in at 7,299. We had budgeted for 7,813 for July. So that's about a 6.6% variance. Emergency visits came in 268 higher than budgeted, 4,799. Getting into the details on the OR and the Cath Lab. Again, surgical cases overall below budget by 24. Joint replacement, really all of our major service lines were below budget. Joints were below budget by 12. Neurosurgical cases, pretty close to budget at 26. Cardiac surgical cases were 5 below budget, and then our other surgical cases overall were 5 below budget. We did have a couple of physicians off that do cases in our joint and cardiac product lines. In the Cath Lab, again, volume off by 40 overall. Our peripheral vascular cases were 4 below budget at 42. Cardiac cases continued to be lower than expected at 80. Our non-vascular cases likewise lower than expected at 52. And our neurointerventional radiology cases came in at 6 against a budget of 7. And again, we had physician vacations in the Cath Lab during the month. Looking at productivity, I'm sorry, my glasses are fogging up on me here. Our productive FTEs came in about 2% higher than budget at 1,350.4. Our non-productive FTEs came in 19.5 higher than budget at 249.9. So we ended up with total FTEs that were 46.1, about 3% higher than expected in the budget at 1,600.3. But our FTEs per adjusted occupied bed did come in lower than budget. That's our productivity measure at 6.18. We had expected 6.52 in the budget. Moving into financials. Total patient revenue for the month came in a little over $2.8 million higher than budget at $189,786,000. Our deductions from revenue came in higher than budget at 77.21% against a budget of 76.93%. Really driven by the payer mix in the month. If you recall from Kimberly's report last month, we did have higher percentage of government payers in the mix, and HMO and PPO were lower than budget. So we end up with our contractuals on insured patients coming in at 75.85% of revenue against a budget of 75.02. We did get a break with private pay coming in lower than expected in the budget at 1% against a budget of 1.6%. So that resulted in our provision for bad debt and charity coming in about $983,000 lower than budget. So again, in total, our deductions from revenue coming in higher than budget at 77.21% against a budget of 76.93. So we ended up July with net operating revenue that was $124,000 higher than budget at $43,753,000. Operating expenses for the month came in $459,000, about 1.1% higher than budget at $43,113,000. Really the big story here was our salaries and wages continued to be high with our higher FTEs in the month. Salaries and wages were about $1.3 million higher than budget. Wow. Our FTEs were 3%. It's about 6.7% variance. Our FTEs were higher by 3%, and we are still dealing with this special COVID sick pay. That added $430,000 to our salaries and wages. That is not a vested benefit. It is not accrued in a bank. So we expense it as it's used. So that's adding on to our salaries and wages expenses. And again, we continue as all hospitals struggling finding staff, and we're filling gaps with overtime and also with some registry people. So that's costing us a bit more. So the higher salaries and wages were offset by a number of areas, one of which was our benefits. They were down $509,000. We had lower health and welfare claims driving that. Also, our pro fees and purchase services were $302,000 lower than budget. We saw favorable variances in our medical fees and services, our recruiting expenses, dues and subscriptions, and repairs and maintenance. So a lot of small variances adding up to that $302,000. Also, our utilities, insurance, and other category was below budget by $148,000. And again, just a number of smaller variances in insurance, utility costs, and our marketing expenses driving that variance. So we end the month with operating income, and again, this is from the Governmental Accounting Standards Board presentation format. This is the format that's used for our audited financials. So from a GASB perspective, we come in with operating income of $640,000 against a budget of $975,000. Non-operating income for the month came in almost $1.4 million, higher than budget at $1,261,000. Big variance there was an unrealized gain in our investments, which we hadn't seen for a while, of a little bit over $1 million. So we end the month from a GASB perspective with total net income of just a bit over $1.9 million against a budget of $881,000. Moving into our Financial Accounting Standards Board format, and this presentation includes adjustments that the financial markets might make to those GASB financials when they look at us. So the first thing we do is we reclassify the interest expense that is down in the from a GASB standpoint down in non-operating income and expenses, and we move it up into operating expenses. So we end up with operating expenses from a FASB point of view of $4,630,000, about $350,000 higher in budget, and operating income of $123,000 against a budget of $351,000. Then we go down into the non-operating area. We eliminate our general obligation bond interest expense and the related tax revenue that supports the debt service on those bonds, as well as that unrealized gain on our investments, because FASB doesn't recognize any of that. And we end up with non-operating income from a FASB point of view of about $411,000, $173,000 higher than the budget of $238,000, and a total bottom line, I mean, pretty close to budget from a FASB perspective of $534,000. Take a quick look at our Ebitda, our earnings before interest, taxes, depreciation, and amortization. This is a way we look at our financial results to get an idea of how much cash the operation may be producing. So the first thing we do is we pull our depreciation out of our operating expenses, and that results in an Ebitda of about $4.2 million, a little bit over $4.2 million for the month. We then look at our non-operating income and expenses, and we separate out our interest expense, and we end up with non-operating income and expenses of almost $2.9 million. So in total, the activities of Washington's operating and non-operating activities produced about $7.1 million in income to support our bond interest payments, capital spending, and program development and other activities of the hospital. So are there any questions on July?
I have a question, Chris. When does this mandatory COVID sick pay end? Is there an end to this, or is it?
Yes. So the state mandated that we provide an additional 2 weeks of sick pay to our employees. And I think it's, oh, thank you so much, Cheryl. And it was supposed to end at the end of this month. It looks like they're going to extend it, and this is the second time they've done this. Looks like they may be extending that, not increasing the amount of sick time available, but extending the time to use it to the end of the year is the latest thing I'm hearing.
Okay.
So it's in addition to the paid time off that they earn as part of their regular benefits. And again, it's not vested, so we have to expense it as it's used, as opposed to paid time off, which is accrued and expense for that recognized throughout the year, and then it gets used by the employee and it's already been expensed.
Very good. Thank you. Any other questions for Chris? Okay. Thank you very much. All right. Kimberly, your operations report.
All right. This evening, I'm going to present the operations report for August of 2022. Starting with preliminary gross revenue, the gross revenue of 196 million for August was above budget by 258,000 or 0.1%, but was below August of 2021 by 11.2 million or 5.4%. Inpatient gross revenue of 112.9 million was below budget by 3.9 million, 3.3%, and 15.6 million or 12.1% below August of 2021. You'll see that although our patient days were close to budget, charges were lower than budget due to lower ICU and IMC utilization. And also inpatient operating room and Cath Lab charges were also below budget. Looking at outpatient gross revenue of 83.1 million was above the budget by 4.1 million or 5.2% and 4.4 million or 5.6% above August of 2021. The favorable revenue variance was driven by higher outpatient volumes. To note, in August, there were 81 COVID-19 discharges, representing 9% of total discharges. This was a decrease of 36 cases from the prior month, but was 11 more than August of 2021, which saw 70 discharges. Moving on to key census statistics, the average length of stay of 5.94 was above the budget of 5.67 by 0.27 or 4.8%. This was also higher than the August 2021 allocated average length of stay of 5.59. There were 14 discharges with length of stay greater than 30 days, ranging from 31 days to 323 days. So excluding these outliers, our average length of stay would be below the budgeted amount. Still in-house at the end of the month, we had 6 patients with length of stay of over 30 days, ranging from 31 days to 87 days. I do just want to say that I know that physicians and staff all work together to really ensure that we've worked with to get these 14 patients to the appropriate next transition level of care, and so that is why we saw such an increase in that length of stay. The length of stay for the 81 COVID-19 patients discharged in August was 9.63 days, which is higher than the prior 2 months COVID average length of stay. Our outpatient observation days at 317 was below the budget of 329 by 12 days or 3.6%, but 2 days or 0.6% above August of 2021. Inpatient daily census of 146.9 was below the budget of 147.9 by 1 or 0.7% and below the August 2021 average daily census of 163.3. The combined average daily census of 157.1 was below the budget of 158.5 by 1.4 or 0.9%, and 16.4 or 9.4% below the August 2021 average daily census. Moving on to the admissions trend, admissions of 850 were above the budget of 808 by 42 or 5.2%. August 2022 admissions were 8 or 0.9% below August of 2021. Looking at our patient days trend, patient days of 4,553 were just below the budget by 32 or 0.7%. and were 509 days or 10.1% below August of 2021. While admissions and the average length of stay were both above budget, excluding those 14 outlier cases, as I mentioned before, we would be below budget. And this resulted in patient days being 0.7% lower than the budget. Looking at our surgical trend, total surgeries in August of 400 were above the budget by 24 or 6.4%. Surgeries were 22 or 5.2% below August of 2021. Inpatient surgeries of 150 were 15 or 11.1% above budget, and outpatient surgeries of 250 were 9 or 3.7% above budget. I do want to let the board and the public know that I know in the past I've talked about the Peninsula Surgery Center started doing cases at the end of May of 2022. The Medicare accreditation survey at the Peninsula Surgery Center was completed on April 28, 2022, and we have been waiting for our Medicare certification number, and we just received that yesterday, September 13th. So we are now able to bill Medicare and contract with our commercial insurance companies and finish credentialing the medical staff with the insurance companies. So we're excited about being able to continue to move forward with Peninsula Surgery Center. Moving on to our surgical activity broken down, joint replacement surgical cases were above budget by 16 or 10.1% and were 5 or 3% below August of 2021. Neurosurgical cases were below budget by 4 or 12.9% and 3 or 10% below August of 2021. Cardiac cases were below budget by 2, 15.4%, and were 1 or 8.3% below August of 2021. And finally, all other surgical cases combined were above budget by 14 or 8%, but 23 or 10.9% below August of 2021. We've continued to have some challenges with Cath Lab. You can see our Cath Lab cases for August at 193 were 22 or 10.2% below the budget of 215 and 27 or 12.3% below August of 2021. Cath Lab inpatient cases at 102 were 12 or 10.5% below budget of 114. And Cath Lab outpatient cases at 91 were 10 or 9.9% below budget of 101. We did have a couple of physicians who were out, and so that was a couple of the reasons for the lower activity than expected. We do have a new vascular surgeon, that Dr. Asuko, that started at the end of August, so we look forward to her beginning her practice here in the district. Looking at the breakdown of our Cath Lab activity, cardiac cases were below budget by 8 or 8.2% and 6 or 6.3% below August of 2021. Non-vascular interventional radiology cases were below budget by 18 or 27.7% and 16, 25.4% below August of 2021. Peripheral vascular cases were above budget by 7 or 15.2%, but 5 or 8.6% below August of 2021. Finally, neurointerventional radiology cases were below budget by 3, but consistent with August of 2021. Looking at our deliveries, we had a busy month for deliveries. For August, we had 131 deliveries, which were above the budget by 12 or 10.1% and 11 or 9.2% above the number of deliveries in August of 2021. Moving on to non-ER outpatient trend, these outpatient visits of 8,200 were above budget by 296 or 3.7%, but were below August of 2021 by 76 or 0.9%. This variance was driven mainly by our cardiac rehab visits, which were above budget by 240 or 36.1%, and 245 or 37.2% above August of 2021. Also, our outpatient wound care has been busy. We've had visits that were above budget by 138 or 35.6%, and 148 or 39.2% below August of 2021. These were offset by EKG and X-ray visits that were below budget by 78 or 3.8% combined. We've had another busy month in the emergency room. Visits of 4,761 were above the budget by 139 or 3%, and 134 or 2.9% above the prior year. I think we've continued to see progressive increases in the ED specific volume. I know when looking at some of the past volume levels, it seems like May, if you combine May, June, and July, that was the highest 3-month period that we've seen. So continue to be busy. Moving on to gross revenue, deliveries were above budget by 12 or 10.1%, increasing revenue by $402,000 or 12%. Our surgical cases were above budget by 6.4%. However, due to lower than expected neurosurgery and cardiac cases, revenue only grew 0.7% or $262,000. As mentioned, our emergency room visits were above budget by 3%, but due to the lower acuity of the visits, the emergency room revenue increase was $110,000 or 0.9%. Our Cath Lab cases were below budget by 22 or 10.2%, and revenue was $398,000 or 2.9% less than budgeted. We did have some charges from the prior period that was captured in August. Room and board revenue was below budget by $1.4 million or 3.9%, and this is due to 20% lower than anticipated ICU and IMC utilization. Lastly, our ancillary services were higher than budget by $1.3 million or 1.4%, and this is due to higher outpatient activity. All right, moving on to our preliminary payer mix. Government-sponsored patient revenue made up 70.8% of our total gross revenue. This is lower than the budget of 71.7% and lower than the prior year's percentage of 74.1%. HMO was 1.8% of gross revenue, which was below the budget of 2.6% and lower than the prior percentage of 2.5% of gross revenue. PPO was 26% of gross revenue, which was above the budget of 24.1% and higher than the prior year's percentage of 22.1%. And lastly, our private pay was 1.4% of gross revenue, below the budget of 1.6% and higher than the prior percentage of 1.3% of gross revenue. So overall, we saw a stronger payer mix this month, I should say, August. All right, moving on to our preliminary productivity indicators. Our productive FTEs were below budget by 12.4 or 0.9% at 1,361.7. Non-productive FTEs were above budget by 35.9 or 19.8% at 217.3. Our total FTEs of 1,579 were above budget by 23.5 or 1.5%. Our productive FTEs per adjusted occupied bed of 5.34 were lower than the budget of 5.54 by 3.6%, but higher than the prior year of 5.09 by 4.9%. Total FTEs per adjusted occupied bed of 6.19 were lower than the budget of 6.28 by 1.4%, but higher than the prior year of 5.81 by 6.5%. I know we talked a little bit about this, but again, the non-productive variance was primarily due to employees on COVID sick leave, and that equated to about 20.6 FTEs of the non-productive time. Moving on to our outpatient statistics, the Washington Township Medical Foundation clinic visits were below budget in August by 211 or 1.2% at 17,971, but were 132 or 0.7% visits above August of 2021. August, we did see some providers take time off, which did impact the budget numbers or the actual numbers. Our DevCo outpatient visits of 2,344 were below budget by 158 or 3% for August, but 58 or 2.5% above August of 2021. This was mainly driven by the Washington Outpatient Rehab Center volume was below budget by 177 or 11.6%. And this was due to having 2 open positions for therapists. We did hire 1 full-time therapist who will be starting at the end of September, but the recruitment for therapists has been very challenging for us, and I think for the whole area. Radiation oncology treatments were above budget by 40 or 11%. Also, the Washington Outpatient Surgery Center visits were below budget by 61 or 10.6%. And again, this was really mainly due to physicians taking time off. Peninsula Surgery Center visits were above budget by 2, and then Ohlone College Student Health Center visits were above budget by 38. Looking at our key financial statistics, days cash on hand for August ended at 162 days, an increase of 4 days from last month. We did see higher cash collections of 9 days were offset by higher operating expenses, which equated to about 5 days. In September, we will be doing the quarterly funding of the pension and OPEB. It will be, the amount will be about $2.9 million. Our days in accounts receivable in August were 62.8. This is down 1.6 days from July and 6.4 days below August of 2021. And then lastly, there were $226,000 in charity care adjustments in August. Are there any questions on the August financials? Or I should say preliminary operations report.
Good. Thank you, Kimberly. We have 2 action items on the agenda. Would you like to go ahead and address those, Kimberly?
Yeah, I want to start by saying, Madam President, that I want to let the board and the public know that the one agenda item B, when we put it on the agenda, when we had put it together for the agenda for last week, we anticipated being ready to talk about the Hospital Bridge project, but it turns out that we will need some additional time for this agenda item, and it will not be heard tonight.
Okay.
And then we will be bringing it back to a future meeting. So we just have the one action item for this evening.
Very good.
Do you want me to talk about that, or do you want? Okay. So the first action item is the approval of the tentative agreement between Washington Hospital and ESC ifpte Local 20 on behalf of the clinical dietitians. The Board of Directors at its June 21st, 2021 meeting authorized the Chief Executive Officer to recognize Local 20 as the representative for the clinical dietitians and to negotiate a contract with Local 20 on behalf of the clinical dietitians. That process has now been completed, and we are requesting the approval and ratification of the tentative agreement between Washington Hospital and ESC ifpte Local 20. We were notified that the clinical dietitians have voted to approve the tentative agreement based on a 6-2 vote in favor of approving the contract. The appendices outline the terms for the clinical dietitians, including compensation changes, including an hourly pay scale and work schedules.
Okay. Thank you. Well, then may I have a motion on action item A, the consideration of resolution 1244, please?
Yes, Madam President, item A. I move that the board authorize the Chief Executive Officer to approve resolution number 1244, tentative agreements to be incorporated inside a memorandum of understanding with the engineers and scientists of California, Local 20, IFPTE, EFL-CIO, and CLC, a recognized majority representative under the terms of Board Resolution 331A.
Very good, thank you. Is there a second?
Second.
Thank you, Dr. Stewart. Okay, Cheryl, roll call, please.
Director Yee,
All right, excuse me.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Nicholson,
Aye.
Director Ethan.
Okay. Thank you. That motion passes. Okay, announcements, Kimberly.
Yes, thank you. I'd like to start with the Employee of the Month, Cecilia Almaguer. She's one of those lucky individuals who understood her career calling from an early age, she says. When I was 10 years old, my grandmother had a stroke. Both at the time and afterwards, my family did not know what to do. Seeing their fear and sense of powerlessness made me want an education and career in healthcare. Cecilia pursued those dreams as she grew up in San Leandro and received her Bachelor of Science in Nursing from California State University, East Bay. 14 years ago, she began working at Washington Hospital on 6 West, primarily caring for post-surgery patients. She earned her wound care certification and happily accepted a full-time role in the Washington Center for Wound Healing and Hyperbaric Medicine. Though many would find wound care particularly challenging, Cecilia knew this was her niche. She notes that while working with inpatients is rewarding, a nurse doesn't see the full recovery like she does with wound care patients. Cecilia says, in the wound care clinic, we help patients improve their daily lives and activities. Often they come in fearful and overwhelmed, and we are able to offer hope. Julie Lentz, the director of Wound Care Department, praises Cecilia's work ethic and her dedication to patients and their needs. Cecilia often takes the extra step on behalf of our patients, Julie says. She performs charge nurse duties when needed and will act as a patient advocate when she believes the patient is a good candidate for hyperbaric oxygen therapy. Working at Washington Hospital has been an exceptional experience, Cecilia says. When I come to work, it feels like a second family, and when a patient enters our wound care clinic, they become part of that family. We treat patients like we would want members of our own family treated. This patient-first ethic and her dedication to her department makes Cecilia the perfect choice for September Employee of the Month.
Yay.
Yay. Just moving on, I'd like to just talk a little bit about some of our health promotions and outreach activities. On August 10th, Dr. Matthew Tenhold, Oncology, presented intermittent fasting for longevity. 316 community members participated in the live event, and since that time, 1,171 people accessed the presentation. On August 13th, Washington participated in the annual Ohana Health Fair hosted by Bay Area Community Health and the Newark Community Center. On August 16th, Dr. Sunil Dewan, dermatologist, presented Sun, Beauty, or Beast. 151 community members participated in the live event, and 267 additional people accessed the presentation on one of our social media channels. On August 20th and 21st, Washington Hospital participated in a wellness and health fair hosted by the annual Festival of India celebration in Fremont. Then on August 22nd, Anna Mazzai, registered dietitian, presented Veggies on the Grill, Make Room for Summer Produce. 144 members participated in the live event, and since then, 269 people accessed the presentation on one of our social media channels. On August 23rd, Elisa Curry, coordinator of Rehab of Clinical Programs, presented information on fall prevention and recovery to the residents of Acacia Creek Retirement Community in Union City. 46 residents attended. August 27th, Washington Hospital hosted a free skin cancer screening at the Nakamura Clinic in Union City. Dr. Sunil Dewan screened 22 community members for skin cancer. Then on August 31st, Maria Nunes, the clinical manager of the stroke program, presented information on stroke awareness to the residents of the Masonic homes, and 24 residents attended. Then on August 30th, we've been busy, it seems like, Dr. John Costoros, orthopedic surgery, presented rotator cuff repair, advances in treatment options. 58 community members participated in the live event, and since then, 371 additional people accessed the presentation on one of our social media channels. September 6th, Dr. Dearborn, orthopedic surgeon, presented Don't Let Hip Pain Win, Updates in Hip Replacement. 166 community members
Wow.
participated, and 429 additional people accessed the presentation on one of our social media channels. September 7th, Washington participated in Polly's Step Out hosted by the Ruggieri Senior Center in Union City. Washington provided blood pressure and blood oxygen measurements to 40 community members. Then on September 12th, Dr. Eldon Eichbaum, neurosurgeon, presented neck and back pain relief, cervical and lumbar disc replacement. 196 community members participated, and then 133 additional people accessed the presentation on one of our social media channels. We've also participated, as you know, on all the Fremont Summer Concert Series that ran from July 7th through August 11th, and over 300 community members were screened for high blood pressure throughout those summer concert series. As of September 12th, a total of 91,996 COVID vaccine doses have been administered to community members at our vaccination clinic. And as you know, Dr. Martin mentioned, we are able to provide the new booster to those who are interested in getting it. I do want to say that it was mentioned that on October 8th at 6 p.m. we will be having the 36th annual Top Hat Gala, and the funds that we raise will be going towards our hospital's trauma center, future trauma center designation for the technology and equipment that's needed. Then also on just upcoming health promotions, on Wednesday, September 21st at 3:30 p.m., Larry Aseo, physical therapist, will present As You Age, Stay Fit, Stay Safe on Facebook Live and YouTube. And and then also on October 1st, we will be hosting our tattoo removal clinic. So those are the past and upcoming health promotion events. Those are all my announcements.
That's it?
Yep.
Okay. Well, very good. We will now go into closed session. However, before doing so, I want to let the public know that they have a right to know what reportable action, if any, was taken by the board during the closed session. Normally, the board would make that announcement following the closed session, but as we do not know how long the closed session will last, we do not want members of the public waiting indefinitely on the phone for the board's report. Therefore, we ask that you contact the district clerk tomorrow. She'll be happy to respond to any inquiries about reportable board actions. Our minutes will continue to reflect any reportable actions taken. Thank you. The board will now adjourn to closed session.